Okay. Thank you. So we looked at progression using a very old version of OCT. In fact, it was a prototype version. And what we found was that you could detect more progression events with OCT than you could with visual fields. However, at the time, we couldn't say whether those were true progression events or if they were false positives. Since that time, there have been a number of studies that have looked at OCT for progression of glaucomatous damage. The most often used parameter has been the retinal nerve fiber layer, although macular parameters have been used as well, and have optic nerve head parameters. As you heard from Bal Chauhan, you can do event-based progression detection, which is based on discrete events, or trend-based progression detection, which is looking at the entire period of time and a rate of change. When you have progression in the retinal nerve fiber layer, that shows up as a widening, deepening, or the development of new defects. Progression detection can occur focally in clock hours, in quadrants, or globally in the mean RNFL. The sectoral glaucoma progression may not be reflected by global progression and vice versa. This is an example of an OCT, a spectral domain OCT, looking at progression over a series of 6 visits. And what you can see is, I'll call your attention to this area here in the inferior nerve fiber bundle, and look here, there's already some development of a thinning of the retinal nerve fiber layer focally, and then that thinning increases, as you can see on the nerve fiber layer map. If you look at the deviation maps, what you see is the first statistically significant progression occurring here at visit 4, and then that progression increasing and then increasing again on visits 5 and 6. If you look at the mean RNFL thickness, the yellow dot is the first progression event that is statistically significant, and then you have additional events after that that are red. And if you look at the inferior nerve fiber layer, that first progression shows up at visit 3. You can also see this on the RNFL thickness profiles, and the area of progression has been highlighted here in a light red. So you see this thinning of the RNFL that has occurred locally, and it shows up on this RNFL thickness profile. Notice that you don't develop a visual field abnormality until here, visit 4, and then that field abnormality changes over time, and this is the event detection paradigm here. This is the trend-based paradigm, as you can see, looking at the slope of change. So OCT can detect progression in eyes determined to have glaucoma progression by other means, such as red-free photography or scanning laser polarimetry. And OCT detects faster rates of RNFL thinning in eyes that have progression on red-free photography. The clock hours in these studies were most sensitive, while the global RNFL was the most specific parameter. And OCT progression OCT detected progression was not seen on photography. There was excellent topographical agreement. Disc hemorrhage, as you've heard from Jody Piltz, is a negative prognostic factor that's associated with glaucomatous optic neuropathy, and OCT will show greater rates of local RNFL thinning in eyes that have disc hemorrhage at the site of the disc hemorrhage. Here is an example of a patient who had a disc hemorrhage here in March 2007, right here at 6 o'clock. You can see that the hemorrhage has disappeared by the next disc photo a year later. And it is very difficult, actually, to see whether or not a change has occurred just on examination of these stereo photos of the discs. However, even with time domain OCT, you can see a reduction in the thickness of the nerve fiber layer on the nerve fiber layer thickness profiles. And the trend-based analysis shows that there is a statistically significant change, again, even on time-based time domain OCT. On spectral domain OCT, you can see this drop in thickness of the retinal nerve fiber layer. And you can see an increase in the area of abnormality in the macula in the ganglion cell complex analysis. This is despite the fact that the VFI, the visual field index, is continuously normal, and there's only this early visual field defect that occurs by 2009. Eyes with progression based on perimetry or photography have higher rates of OCT measured RNFL loss than their stable counterparts. And these studies have shown that whether time domain or spectral domain OCT is used, the rate of RNFL thinning is greater in the eyes that show functional damage than those that don't. The deep optic nerve head structures have also been looked at, most specifically the lamina curbosa, but also the prelaminar tissue thickness, the ILM, the mean rim width, rim volume, and neural canal opening. In studies that have looked at macular parameters like macular volume, total macular thickness, ganglion cell complex, ganglion cell layer, interplexiform layer, there's also the demonstration that there are greater reductions in tissue thickness in eyes that have progressive visual field loss or show loss by photography. In cases of advanced glaucoma, total macular thickness had greater rates of reduction in both visual field and photography determined progressors, and macular parameters also outperformed the retinal nerve fiber layer closer to the fixation point. Although OCT detects greater rates of nerve fiber layer atrophy in visual field progressors, agreement tends to be poor when glaucoma progression is defined independently by structural measures such as OCT or functional measures such as perimetry or multifocal VEP. So in most cases of agreement, structural progression precedes the development of functional deficits, and retinal nerve fiber layer deficits in preparametric glaucoma are predictive of future visual field loss. So to conclude, OCT can be used to detect glaucoma progression. Early glaucoma that progresses may only show OCT damage. Without a visual field abnormality, the retinal nerve fiber layer is the best studied OCT parameter, but macular and optic nerve measurements may also have utility. Thank you very much.